Hi guys, I'm Olivia Beaubrun. I'm the first year Penn Fellow. I'm going to give a lecture on bites and stings, which is in alignment with our environmental theme. I have no financial disclosures. So today we're going to discuss animal bites, snake bites, human bites in children, and jellyfish stings. So dog and cat bites, why is this an important topic of discussion? It's actually, dog bites are actually considered a public health issue and quite preventable. So about 5 million dog bites and around 400,000 cat bites occur in the US annually, including kids and adults. Kids are the most commonly injured of this group. Most dog bites occur in male children, around 5 to 9-year-olds, versus most cat bites occur in adult young women. Dog bites make up about 90% of all animal bite injuries, and usually occurs with familiar or family dogs, and more often provoked injuries as opposed to unprovoked. And this is because kids tend to be more comfortable interacting with the family or familiar dogs under less supervision. And dog bites in younger kids, so less than 5-year-olds, usually occur on the head and neck because of their smaller stature. They're usually at the same eye level as the dog, like in this picture. They're also very fearless, and so they may provoke or even bite the dog and bring their faces at kind of a threatening or intimate distance from the dog. Versus older kids, usually you'll see dog bites on the extremities. Younger kids are also more likely to be hospitalized for severe dog injuries than older kids. Versus cat bites usually occur on the arms or hands of all ages. There's a greater susceptibility for infection with cat bites over dog bites because cat bites are by definition puncture wounds. It's always really important to ask, of course, about the mechanism of injury so you know what to look for. Some of these wounds can really appear innocuous or kind of superficial at the surface. And then the most common pathogen in dog or cat bites is Pasteurella, followed by staph strep, anaerobe, and Pasteurella infections have a more rapid onset of symptoms compared with these other pathogens. So they're typically develop pain, swelling, or drainage from the site within 24 hours. So there are certain important factors that increase the risk of infection following animal bites. So these wounds should be left open to heal by secondary intention as opposed to primary closure. So some of these factors include immunosuppression, so your neutropenic children, kids on chronic steroids, immunodeficient kids, kids with diabetes, particularly type 1, and then asplenic kids. Bites involving the hand or foot and genitals, and this is important because the hands and feet generally have poor wound supply. And then bites with or bite wounds with suspected joint, bone, or tendon involvement, bites near prosthetic joints, less common in kids but possible, and then crushed injuries or puncture wounds. So again, cat bites carry a higher risk of infection because they are puncture wounds, so there's a higher risk of abscess development, septic arthritis, osteo, bacteremia, and even necrotizing soft tissue infection. And with puncture wounds, there's a higher risk of infection because there's a deeper area of deposit for the pathogens, and then irrigation also becomes more difficult than the open lacerations that you might see with dog bites. So because of this increased risk of infection, secondary intention is more favorable to primary for cat bites, except on the face. And then other factors that kind of increase the risk of infection in animal bites include delayed presentation, so greater than 12 hours for extremities and then greater than 24 for the face, and then bites in the extremity with like an underlying venous and lymphatic compromise. Facial lacerations following animal bites actually require primary closure. So the Infectious Disease Society, or IVSA, recommends against primary closure of dog or cat bites except for on the face, because the face is cosmetically important and has a lower risk of infection relative to other parts of the body because of the rich blood supply. So management of dog and cat bites. So the wound should be thoroughly irrigated and cleansed, but high pressure irrigation should be avoided in puncture wounds. You should obtain a wound culture for infected appearing wounds. And then antibiotic prophylaxis should be used for all primary closure of dog or cat bites. And they should also be used for clinical uninfected wounds, plus one of the other criteria that I mentioned in the other slide that have increased risk of infection. And then the first line of choice for antibiotic is augmentin. But alternatives include, like, for example, with a penicillin allergy, you want to use Bactrim and clindamycin, and then there are other alternative antibiotic regimens. But these are the primary or first line antibiotics used. And again, you're covering Pasteurella, but you also want to cover staph and strep and anaerobes found in oral flora. So wound management and tetanus prophylaxis. So you want to administer tetanus prophylaxis if the patient's vaccine status is not up to date. TIG tends to be overused, and I just want to clarify on the upper right-hand side, the all other wounds. In tetanus prophylaxis, because it's not an all catch category. So all other wounds includes, but is not limited to, wounds contaminated by dirt, feces, soil, saliva, puncture wounds, so your cat wounds or cat bites, avulsions, and then wounds resulting from missiles, crushing, burns, or frostbite. So essentially, if the wound does not have obvious contaminants in it, it's considered clean and minor, even if it's a deep, large lac, like from a dog bite, for example. So the clean and minor wound group is more encompassing than most people think. So for example, if you have a puncture wound from a cat bite, it would fall under all other wounds. If the patient or the child has less than 3 doses or a known vaccine status of tetanus, then they would get both the vaccine and the TIG. But for a dog bite, for example, with an open laceration, no obvious contaminants, and a child with less than 3 doses, or basically not up to date with vaccinations, or unknown, they would only receive the vaccine and not the IG. And then just a quick word on rabies prophylaxis. I'm not going to go through the entire chart, but post-exposure prophylaxis also tends to be overused. So most states actually have an annual rabies, annual rabies surveillance data. And per our data, NYC hasn't had a rabies positive dog in decades. So it's actually very uncommon as it pertains to dog bites. Most of our dog bites tend to be provoked, which is not an indication for rabies prophylaxis. And keep in mind, if the dog is owned by someone, then it essentially does not have rabies, even if the victim does not know the owner or can't follow it. But for those requiring post-exposure prophylaxis, the human rabies IG would be injected around the bite site at the time of the visit, plus the 4 series rabies vaccine at 0, 3, 7, and 14 days. And then went to consult surgery. So for complex facial lacerations, deep wounds penetrating the bone, tendons, or joints, and neurovascular compromise. All right, so cat scratch disease. So the main pathogen transmitted is Bartonella, hence why. So transmission is typically by kittens rather than adult indoor cats, also by outdoor cats or cats with fleas. So typically kids with cat scratch present with a localized skin or cutaneous lesion and regional regional lymphadenopathy. But atypical findings include visceral organ involvement, ocular or neurologic manifestation. So for cutaneous findings, the lesion at the site usually develops at about 3 to 10 days after introduction of the organism into the skin, and usually evolves into vesicular, erythematous, or papular phases. So that image on the bottom right is an example of the cutaneous. But regional lymphadenopathy is actually the hallmark of cat scratch. And so you'll see in the patient enlarged lymph nodes, developing about 2 weeks after the organism enters the skin. Most common locations are axillary and supraclavicular, but you can also see at the cervical and submandibular lymph nodes. They're usually very tender. Erythema kind of overlies the skin, and they can also be suppurative. The lymphadenopathy usually resolves in about 1 to 4 months, but there have been cases persistent enlarged nodes for about 1 to 3 years. And then treatment is generally azithromycin for 5 days first line, but you can also use rifampin or erythromycin or Bactrim for 7 to 10 days. And then for visceral organ involvement, very atypical but very important manifestation, usually involves the liver, spleen, or both. And you can see this with or without the adenopathy. And then treatment for the visceral organ involvement includes rifampin for 7 to 10 days plus Visipro. Okay, so on to snake bites. So pit vipers, the really scary ones. So the most common venomous snake in the US actually occurs from pit vipers. There's the appearance of the poisonous versus the non-venomous type of snakes. So on the bottom left, you'll see the venomous appearance. They usually have a triangular shaped head, elliptical pupils, huge fangs, and then this heat sensing pit between their eyes and their nose versus for the non-venomous snakes. They usually have more of a round head, round pupils, no fangs. And then about 25% of these snake bites are dry bites, which basically means that they're non-venomous or no envenomation. And they'll only result in only local tissue irritation. So typically with these kind of bites, you'll see local tissue damage with progressive swelling. You can also develop systemic symptoms, tachycardia, hypotension, tachypnea, nausea, vomiting. What you really kind of want to look out for is coagulopathy and rhabdo. And then shock can also occur secondary to coagulopathy and hemorrhage resulting in hypovolemia or this direct vasodilatory action of the venom. Less commonly, severe tissue necrosis can occur, as well as compartment syndrome. And there have been a few cases of neurotoxicity as well. Versus coral snakes, so these are much less common than pit viper bites. These snakes usually have a small kind of oblong head, no heat sensing pit, and then short hollow fangs. And they'll usually have red and yellow bands, so that's on the top. There's that fun little mnemonic, red on yellow, kill a fellow, red on black, venom lack. So the similar appearing snakes on the bottom are the ones that lack or are basically non-venomous. And that's just kind of a quick mnemonic used to distinguish these similar appearing snakes. These snake bites usually have or result in minimal tissue damage, but rather more so not neurotoxicity because of the neuromuscular, postsynaptic neuromuscular blockade of the ACH receptors by venom. So this results in muscle paralysis, including cranial nerve palsies, ptosis, dysarthria, dysphagia, and even respiratory failure. So you could think of this as similar to the clinical effects of myasthenia gravis. And then the onset of systemic effects can be delayed for hours. And then this is a little bit more for pre-hospital care, but do's and don'ts of snake bites. So you want to keep the child warm, immobilize the body part about heart level depending on systemic symptoms, and provide local cleansing and wound care. You want to cleanse with iodine containing solution or chlorhexidine, remove any visible foreign bodies, and then tetanus prophylaxis if they're not diseased. And then as far as don'ts, you want to just kind of avoid constrictive clothing, jewelry, tourniquets, any sort of constricting mechanisms. because this can really, especially for pit viper snake bites, can sequester the venom in the affected limb and increase the local swelling damage, or local tissue damage and swelling. But it actually, studies have shown that constriction can also be useful in preventing neurotoxicity caused by coral snake bites. So for pit viper, less so, but more so for coral. And then antibiotic prophylaxis is actually not indicated because infection at the site is usually rare. And then antivenom, so fab, AV or profab is commonly used. The fab fragments bind the venom in the intravascular space, and it's renally excreted. Most effective when given within 6 hours of the bite, and for pit viper bites, usually applies when there's a bite on the head or neck, or for moderate or severe toxicity. Versus for coral snake antivenom, usually decreases the risk of neurotoxicity. Patients with mild symptoms can be observed just very close monitoring for 12 to 24 hours without being given antivenom. All right, so human bites. So there's two main types, occlusal and the clenched fist wounds. So the likelihood of infection after human bite is really determined by the depth and location of the wounds and host factors. Infection rate ranges from 2% for superficial wounds, roughly about 10% for occlusal bites, and about over 25% for clenched fist wounds or other wounds to the hand. Main pathogens include, so human oral flora, Eikenella is the primary pathogen, but there's also other pathogens, including group A strep, and then the oral flora anaerobes, and then human skin flora like staph and strep. Human bite wounds can also be associated though with transmission of Hep B, Hep C, HIV, and H. So for occlusal bites in children usually occurs on the face, upper extremities, or the trunk. It's usually a result of aggressive play, and those wounds are a little bit more trivial. But the reason I bring this up is because you really want to raise your suspicion for child abuse with these kinds of bites. Any bite mark on a child. They say with a maxillary intercanine distance of greater than 2.5 centimeters from an adult is considered child abuse. So these are two images that should raise suspicion, but this image on the bottom should also really raise suspicion because you can see that shape of the kind of maxillary intercanine space there. And then clenched fist wounds, you guys probably see this all the time. So it's technically termed clenched fist wounds, but also referred to as spike bites. And then in the pediatric group, these injuries are most common in the adolescent male. So the bite injuries to the hand usually occur with the fist in a clenched position when the fist makes contact with the mouth. The teeth can easily penetrate the skin and the extensor tendons that are stretched tightly over the metacarpal head, and therefore can injure the underlying opponent joint. Many patients actually tend to ignore these wounds until they really intensify with pain, swelling, and purulent discharge. And so as a result, they're often complicated at the time that they actually seek medical attention. So for these reasons, wounds over or near the MCP joints should really be explored carefully in both the anatomic and the clenched fist position. So you really want to assess for any foreign material or teeth, signs of infection, neurovascular compromise, and damage to the underlying tendon sheath, fascia, joint capsule, or metacarpal head. And then bite wound infections can be superficial, so a superficial cellulitis with or without abscess, or deep with concern for abscess, septic arthritis, osteo, or necrotizing soft tissue infection. And augmentin is generally the first line. Again, includes coverage of Eikenella. which is oral flora, but you can, or found in the oral flora. You can also use clenched or flagyl with doxycycline or penicillin, among others. And again, tetanus prophylaxis should be used for those who are not up to date. And then finally, jellyfish stings and sea anemones. So jellyfish stings usually result from envenomation of nematocysts, which are basically toxin producing substances that are released from the tentacles. So patients will usually have immediate pain, and then minutes to hours later, they'll develop these linear erythematous urticarial lesions that are super, super itchy, burning, throbbing, and can radiate up to the trunk. And so the reaction is typically localized, but you can also see systemic symptoms like nausea, vomiting, headache, altered mental status. Multiple cases of anaphylaxis, shock, and rapid cardiac arrest have also been reported with Australian species or box jellyfish. So if someone comes back from vacation from Australia, that's something to look for. And then skin necrosis can occur with more severe stings. In some cases, these papular urticarial lesions can recur 7 to 10 days later. And again, they're usually typically extremely pruritic and itchy. And the lesions usually resolve within about 10 days, but can persist for weeks. As far as management, so removal of the tentacles from the affected limb or region is usually done by gently brushing off the tentacles with a plastic object like a credit card, or applying adhesive tape to the skin and pulling off the tape to remove the nematocysts. You really want to avoid vigorous rubbing or pressure because this can actually exacerbate toxin release. And then studies have shown the effectiveness of various different remedies depending on the species or geographic area, but the most favorable is application of vinegar. And that actually inhibits the discharge of these toxin-producing cysts from the tentacles. So therefore preventing further envenomation. As far as symptomatic control, so hot water emergence, so hot showers or hot packs to the affected area are recommended over cold. And that's really your therapy for significant pain. And then there's that myth about urination on the jellyfish sting site. That's actually really a myth. There's no scientific support for that, and actually can worsen pain. And then lastly, so the reason I brought up sea bathers eruption is because this is commonly seen in Florida and the Caribbean, but also in Long Island. And so essentially it's an itchy dermatitis. This dermatitis occurs on parts of the skin that are covered by bathing suits caused by jellyfish and sea anemone larvae that become trapped between basically the skin and the bathing suit. The reaction can recur when the outfit is worn again because of persistence of nematocysts that are in the fabric and release. And so other symptoms, like GI and fever and malaise can occur, but less commonly. And then treatment is very much treatment of the symptoms. So this consists of oral antihistamines like Benadryl or hydroxyzine, topical agents like calamine lotion, and then topical steroids, low or medium potency. For severe cases, you can use oral steroids, so PrEP, and then these skin lesions usually resolve spontaneously in a week or two. And you also really want to encourage removal of the swimsuit and then showering after ocean bathing to prevent it. Any questions? Any comments?
I only have one comment.
Yeah.
Which is like sometimes we talk to families after they get bitten by a dog or like someone from my dog and they're really adamant about the rabies prophylaxis. And I just explain to them it's like a 6-month thing where they have to come in at 1 month and then again at like 2 months. They have to come to the ER multiple times. So lot of patients with it. So, just because they ask for it doesn't mean that you have to give it to them. Just talking to them through the process and you're looking to be really helpful to make them feel more comfortable.
Yeah, that's a really good point, especially because the post-exposure prophylaxis is really overused. And depending on the region that you're in, you really want to kind of take that into account. So it's a good way to talk to parents about.
I guess another thing about dog cat bites, you mentioned that, face is where you're going to do cosmetic repair. I think another thing to keep in mind is functional repair as well. It's going to affect function, scar tissue. So thinking about that, hands and other places where over joints, and you will do a loose approximation to kind of prevent any function.
Yeah, that's the point.
All right. Thank you.
All right,
Olivia.
thanks.